for the crane. So I'm gonna start with frontal bone, just for funsies. So sinking in above the brows, this is like a suction cup technique. So we have to take the time to sink into the bone. My hands are very light, at 5 grams of pressure. I'm trying to sink through the skin. I'm really thinking about bone. And then when I have that connection, I'm gonna give a gentle lift to the frontal bone through intention and with like a gentle change in my pressure. And then I'm just kind of following that frontal bone as it kind of unwinds, does its thing. Okay? And then when we come into parietal bones, we're following, I like to put my finger pads just kind of on that curve of the skull where it comes around, because then I know that I'm off the temporalis muscle. So using my finger pads, just really light pressure, sinking into bone. And this is kind of a two-parter technique. I'm giving a gentle squeeze, like again, 5 grams of pressure between those parietal bones together, so fingers coming together. And I'm waiting for that suture between the temporal bone and the parietal bone to kind of give a little ease. And when it does that, I'm gonna release my pressure. I don't have to take my fingers away, but I'm releasing my pressure so that that sagittal sinus can fill up again. And then I'm bringing contact in again, and then I'm gonna do a parietal lift, so towards me, superior. For the temporal bones or the ear pull, bilaterally, I'm just letting my thumb rest kind of inside. If I can get as much cartilage as I can without kind of getting into like wet ear hole, that's what we want. And I'm thinking about that tentorium between my fingers. I'm not trying to just like stretch ear cartilage. I'm trying to think about that tissue between my hands and the brain. And then I'm gonna give a gentle lateral traction bilaterally and a little bit posterior. And I'm feeling for where that tension is. Same with any other fascial release. I'm kind of finding that tension, I'm sitting at the border, and I'm waiting for the tissue to release.
But you're not squeezing the ears, like it's just
I'm using the ears as a handle for sure, but
Okay.
I'm not pinching them. Yeah, no ear pinching. Okay. And for single ear pull, I'm just kind of cupping under the neck around to the mastoid process. Try not to pull her hair. And same thing, hand placement on the ear is the same. I'm just thinking about trying to release that posterior aspect of the temporal bone from the occiput. And then we have mandible. So we have compression, decompression of the mandible. So just on that inferior border, I'm sinking in, I'm thinking about bone. And then there's just compression into the joint space. So a little bit of pressure towards me, superior. And then this is essentially a like ligamentous articular strain technique for the jaw. You can kind of play around a bit, find that place of ease, and then the body's gonna unwind. Great. Same thing, different name. For decompression, I'm coming up to the joint space. I just use kind of 2 finger pads, and I sink in below the zygomatic arch, and I'm thinking about bone, thinking about that joint space, taking a second to sink in. And then I'm doing a little bit of traction inferior with that 10% anterior. So kind of like you're going this direction. Okay, that's the jaw. Anterior. You're kind of like jutting the jaw forward into the joint space a little bit. Yeah. What else is on? Other
And
than
now
this
we're
feeling?
yes,
Okay. So when we do our vault hold 3, I'll go through the 3 vault holds too. So vault hold 1, ring finger on the mastoid process, just anterior to the ear and then to the zygomatic arch. And I'm assessing the movement of those temporal bones. and the tentorium in between. So ideally we should have kind of like that like fish gilly type of movement coming for the temporal bones. Oftentimes if the tentorium is tight, we'll get this alternating business happening because it's so tight it can't expand, so it has to alternate. Yeah? And then vault hold 2, we're just cradling the occiput, and then middle finger is tracking down the center of the frontal bone. And we're kind of trying to feel for that clamshell movement. So this kind of like opening, closing. Again, if a falx is tight, they might move together. So instead of a this, we might get a this. Yeah. And then vault hold 3, thumbs on the greater wing of the sphenoid, just off the brow. And I'm assessing for that flexion, rocking this way, extension, rocking this way. When we're coming in to assess a strain pattern, we are going to isolate the sphenoid by immobilizing the occiput. So I'm feeling through the cranial rhythm. And when I am between flexion and extension, when I'm in that neutral position, I'm going to use my pinkies on the occiput to give a little bit of a compression anterior. That will stop the cranial rhythm, essentially, so that we can assess the sphenoid without movement. So when I'm assessing the sphenoid, I'm checking for flexion extension, so bilaterally trying to go into flexion and into extension. I'm checking torsion by bringing one wing to the feet, one wing to the feet. I'm assessing rotation, so left up, right down. And then I'm also assessing for shear, so the whole sphenoid going to the left and to the right. I'm doing all of those at the same time. Yes? Makes sense to everybody? So when I assess all of them, it's kind of like I'm doing a full assessment of the sphenoid to see what's the most stuck. So of those movement patterns, which one is like, there's like a, oh, it really is easy to go this way, but it really can't go that way, or this way, or this way, or this way, or this way. Yeah? I'm choosing whichever one of those feels the most stuck, and I'm treating that one by going into the direction of ease first, and then I'm going in the opposite direction of that in that movement pattern. So if it really likes to go this way, doesn't like to go that way, I'm going to treat this way first. It's going to do a little like, yep. So this is torsion. So towards feet is torsion. Yep. Flexion extension is like a steering wheel, or sorry, flexion flexion rotation lesion. I don't know why flexion is there. And then shear. Is that what it's called? Shear, right? Yeah. Shear is like a whole shift. Yeah. So straight lateral to the left and to the right.
So question, do you treat after each assessment, or you assess the whole thing before you start treating?
I generally assess the whole thing. So I'll do those like 6 strain patterns. Mm-hmm. So the this, yeah. this, mm-hmm. this. Okay. I'll choose which one is the most stuck. And in that most stuck one, I'll treat the direction of ease in that stuck pattern first, and then the sticky one. And then I'll reassess the sphenoid. Yeah? Clear as mud. So occiput's coming into flexion. In flexion, I'm kind of holding it so it can't come back into extension. And I kind of just like squeeze my thumbs together, like a little volleyball hold. Sorry, Ella, I'm putting you in and out here. You volunteered for a bad thing.
Mm-hmm. Before doing that, should you do like the diaphragm release?
Before doing a CV4. If one of their diaphragms was really stuck, then I would probably do that. But again, CV4 is kind of like a global treatment, and it will make your tissue more receptive to treatment. So CV4 could be like one of the first things that I do. Yeah.
Because it has to go somewhere.
Yeah, that you open the doors or whatever.
Oh, yeah. I mean, generally for fluid flow in the body, diaphragms are great, but it's kind of like the chicken or the egg situation.
Yeah, I got you.
They're both going to be helpful in both directions.
Right.
Okay, yeah, so that's CV4. And then we're gonna come into dural tube, dural rock. How do you guys feel about dural tube assessment? Do we need to do that one? Yeah, okay, cool. Yep, so I'll just get to lift up pelvis for me. Yeah, good. And down. Again, I'm not a big fan of the between the legs. Could someone grab a bolster for her knees? That'll just help with the twist. So we can assess the dural tube from the top or the bottom. We can have different restrictions from the top and the bottom. Fantastic, thank you. So my fingers are just curled around the sacral base right now, and I'm just kind of like letting the tissue kind of chill. I'm not doing anything out of it yet. I'm just kind of sinking. And I'm trying to think about the dural tube. I'm thinking about inside of the spine, around the spinal cord. I'm thinking of that cerebrospinal fluid. And honestly, all I feel right now is like erectors and QL on the left side. So, sometimes, dural tube is a really deep structure in the body. So sometimes there's stuff on the outside of that that is causing too much tension in your hand for you to actually get into that deeper structure. So to me, that is an indicator I'm probably gonna need to do something in this whole kind of left back situation, which we know from this morning. It's a bit of a yowie bit. But if I was able to get into the dura, then I would just kind of do a slight, like a 1 gram traction onto the sacrum to start trying to lengthen those spinal segments up through the dura to see how it's moving. So something real stuck here. And then the thoracic spine doesn't feel like it's moving great, but I am getting some movement there, and then it definitely feels like there's something going on around kind of like T1 and then also C1. T1, C1. This can be an assessment that leads to treatment, or it can just be assessment. If you want to treat these areas, you kind of just stop your tension there and the body's gonna unwind. If you want to assess and kind of like feel what's going on in the whole spine, just add a little bit more pressure and you'll kind of bypass that tension so you can see what else is going on further up the elastic band. Okay. Okay, cool. Since we're on that same line of thinking, I'm going to come up here. Oh, skirt, don't do this today. And we're going to assess the dural tube from the top. So again, just kind of curling my fingers into the occipital base. And again, I'm feeling a lot of tension in like her posterior longitudinal ligament as opposed to her dura, which is very common when we come in to assess. The dura has more of a fluidy texture to it than a ligament does. So as your palpation skills get better, you'll start to be able to kind of like isolate different structures. So as I'm here, again, I'm just adding that kind of 1 gram of pressure. Yep, C1, still very present here. T1, still very present. Yeah, little something going on around T12. It feels more like T12 than kind of like L1, like it did from the bottom. And then definitely lots of tension around the sacrum from here. So yeah, just adding that 1 gram of pressure. If I stay at those kind of locales, even C1 is starting to kind of like chill out a little bit just from being here. And while I'm here, I'm gonna do our occipital cranial base release, which is shockingly the exact same position. My intention is just a little bit different. So I'm doing a soft tissue release between the occiput and C1. So I'm just waiting for that tissue to release.
So you can do 2 different functions
All the time. Yeah. It's really, like you will find throughout all of this, hand placements are gonna be literally the exact same. It's just what your brain is focusing on. Yeah.
Maria did this for me on Thursday, and my neck pain disappeared.
Yeah.
Do you think the dural tube too?
Yeah.
Also.
Yeah. So great.
I was having that.
Yeah, so with OCBR, we're just doing that soft tissue release. You can come into a platform to get deeper. I also find if you just hang out with it longer, the tissue will release more deeply because you're waiting at the tissue barrier. There's quite a bit of tension here, and we're not gonna have time for me to go through this whole thing, unfortunately, for But the second part of, or the third part of the OCBR, so first part is gentle tissue release, then you can come into a platform, and then you can come into a spread, so bringing the occiput towards you.
No,
and
gap.
then the gap, yes, sorry, you're right, gap. Occiput towards you, and then on the spinous process of C2, you're kind of giving a little bit of traction, creating some space between those. And then for the spread, you're sinking into those occipital aspects, like superior nuchal line, and you're thinking about trying to spread that bone laterally from each other. Yeah? OCBR? Okay. And dural tube. So I'm cradling occiput. Oh, sorry, I'm gonna do a hand thing first. No, I'm gonna show with my hands first. So in normal cranial rhythm, we're kind of doing a this thing. Yeah. In a glide, we're kind of gliding both, just giving everything a little nudge, one direction. And that's gonna come the opposite way, a little nudge in the opposite direction. In a, nope, that was wrong. That was a rock. Rock, sorry. Rock is doing both of them at the same time. A glide is just doing one. So when they come like this, I'm gonna stretch one end. Okay.
Could you explain the second one, the rock one?
So this one is the rock, both of them together.
Slowly on.
And then a glide is one kind of stays stationary and we're like stretching one end. Yeah. Okay. Hand placement for that is just gonna be on the superior aspect of the sacrum and the occiput. You're finding your cranial rhythm. So coming into extension. And then into flexion, and I'm kind of just like nudging the two of them one direction. Nudge. Nudge. And then for glide, when I come to that aspect, I'm gonna kind of stretch the occiput. It's not a big movement. The dura is not like we're not moving inches here. It's just a gentle glide.
So is it just you putting more pressure to?
Just a nudge. Yeah. We're just kind of trying to help expand its space so it can actually have a fuller movement. And you'll find that when you kind of stop doing it, you'll feel the cranial rhythm just be more. Yeah. This one is not in your book, but you can also just kind of treat along the dural tube. So if I'm feeling a lot of restriction in lumbar spine, like I am in Bella's body, I'm bringing my finger pads onto the spine, and I have the intention of trying to help the dural tube right here move better because it's kind of stuck.
What part of the spine are you putting your hand?
Oh, just right in the center, like on the spinous processes.
Is it L3, 4, 5? And then this one.
It's wherever I'm feeling the restriction. Yeah.
Okay.
So if it was really up into like T-spine, I'd just come up there.
Okay.
And maybe it's more T-spine and occiput. Again, wherever you're feeling like there's more restriction, put your hands there.
Finger pads? Or
Yep, I'm not digging my fingers, but I just have my finger pads resting on the spine with the intention of sinking through the bone to that dural tube. Because we can't get to the dural tube, right?
Do we need to move it or just leave it?
You can do whatever feels right. If it feels like a stretch, if the body responds well to like a little stretch, great.
So it goes to both transverse processes of the spine, right?
Not really.
Just one?
Nope, spinous processes, right in the center.
Okay.
Yeah. Midline. Okay, cool. Was there anything else on that list? Sarah?
Well, review squat.
Oh, yeah. How do you guys feel about squat?
Mm-hmm.
Eh?
And also the assessment for the tentorian on the ears. Like this?
Oh, we did vault hold one. Okay, yeah, yeah. I can do
The
that one.
ear one.
The ear one, yeah. We did do one ear one, but we didn't do the other. And the other one's not so big. Quality is like, is there bounciness? Is it like really big and boisterous and vibrant, or is it kind of like quiet and still? So quality is more if it's like bouncy, amplitude is if it's big. Thank you, I'm sorry. And rate is going to be counting how long it takes to go from flexion to extension back to flexion, or extension to flexion back to extension. Okay? Okay.
So in amplitude, and this is just
Yeah.
for non-moving
Yep.
kids, if it seems bigger in extension and then
Would that be symmetry or amplitude?
I would say amplitude, yep. Because symmetry would more be like if the right one is doing it, but the left one is not. But if they're both equally doing it, then that's going to be symmetry.
Okay. Okay.
So we would do that on dorsum of the feet, or bottom of the feet, dorsum of the feet, shins,
Thighs.
thighs,
Yes, yes.
hips,
Diaphragm.
Sorry.
ribs,
I mean the ribs. Shoulders.
shoulders. And then we go into our vault holds.
Yeah.
Yeah? The ear one. So you, again, with your vault hold, I find you can get your assessment of the tentorium. If you want to do the specific one in the ear, you just move that finger that was in this vault hold into the ear. And then I'm assessing for how those are moving together. I'm not digging my finger into the ear, just resting it over the hole. And we're always talking to people about if they're okay if their ears are getting touched. Yeah? We are, number one, sinking into the tissue. I'm sinking through the pants, sinking into that superficial layer of the fascia, and then I'm checking my kind of like 6 cardinal directions. So superior, superior, inferior, lateral, lateral, rotation to the left, rotation to the right. And if I was going into a indirect treatment, I would choose the direction that it likes to go better. So indirect is into ease, direct is into bind. Yeah? Straight on the clock. Boom. Nailed it.